when I first got involved in pro-life work, the first conference I ever went to was an Alliance for Life Ontario conference. And I remember Jackie, and I remember the kindness and the compassion, the grace, and now over the last 10 years, I've also had the privilege of seeing the courage. And so thank you to all who are here willing to give their time to think about how can we do things differently, do things better, and make a difference for the ones in our nation who need us to have a voice and to speak up. So my talk today is abortion data, why it matters. And I realize like after lunch, it doesn't sound very exciting. So I'm hoping that it can be a blend of the work that I'm now involved with and then also touching on some data. We do live in a time where ideology appears to matter more than facts. We see that all the time. How can they not be looking at these numbers? Why are they not looking at the laws? Why is there no feedback mechanism to make sure there's safety? We also live in a day where abortion access seems to matter more than safety. The government, the Liberal government, more recently has really focused on increasing abortion access without necessarily looking at all the safeguards that should go along with such an increase in access. And we also are in a time where opinion and intimidation appear to guide decision makers. And that isn't okay. That I think we should expect more from our leaders. And I think that is part of what we are trying to do and talk about today. How can we have that influence? So I do want to talk a little bit about my story because I would never have imagined that I would be here standing in front of you talking about this. For 22 years, I worked as a family doctor, and for half of that time, I did not have a worldview that felt that abortion was wrong. I wasn't a believer, so I referred many women for abortions. I didn't think much about it. I didn't ask many questions. I didn't understand the impact of abortion on women and men. And even though I knew all of the science, it was strangely separate from my recognition of the beauty and dignity of all life. But then that changed, and I feel that the greatest miracle of my life was at 41, I was saved. I met my Lord and Savior, Jesus Christ, and that changed everything. I went on a medical mission trip down to Guatemala, and in the mountains, I encountered the Lord, and I came home changed forever. But it didn't immediately change my understanding about human life and the dignity of each life and my role as a physician. But over time, God was gracious and slowly revealed to me the importance of each life. And then I began to practice from that awareness. One of the first patients, she wasn't a patient, her brother played hockey with our son, and she had Down syndrome, and I remember seeing her and thinking how her parents made room for her, how she brought a lot of joy to wherever she was. She would sometimes sit beside me watching the hockey game, and I felt this conviction, who am I to decide that her life doesn't matter? And God just kept poking at these things. And then I began to realize that the patients who were coming into me with an unplanned pregnancy, that there were so many circumstances affecting their decision. And I started to hear the stories and realize that they needed more than what I could provide. I didn't have the time, I didn't have the understanding, and I didn't have the resources. And so I ended up working with a group, and we started a local pregnancy care center. And that is part of why I'm here today. As we started this center, then women in the community and in my practice started telling me about their abortion experiences and how they felt afterwards. And I realized that I had never asked the questions, so I never had heard their stories. I didn't feel I had a choice. No one was there. If only someone had said, you can do this and we'll help you. And I have had the privilege of watching how these local pregnancy care centers really do enter that gray space between maybe what we know is right, but what we see is happening. And then there's this messy space in between. And we do all enter the pro-life work from different points. And I do want to acknowledge that today, that we might be in this heart, like the maybe less clear pastoral area, but I truly do honor the work that is being done in some of the other realms, the legislative realms, the however you might define yourself. But this, my perspective is really coming from the pastoral arm of the pro-life movement, where we try to walk alongside people in their despair and distress and try to help them find hope. As I was, hang on there, as I was contemplating all of this, I do remember one day this young woman came in and she started telling me her story. She saw the poster for the local pregnancy care center on the wall, and she said that when she was 14, she and her boyfriend got pregnant, and her boyfriend's mother forced her to have an abortion that she didn't want. And she said, I think about my child every day and wonder what they would be like. And that was that sort of moment in time where something really gripped my heart, and I thought, this isn't good enough. We can do better, and we will do better. And that, again, is part of this collective hope that we can do better and we will do better. So abortion, hang on, I went backwards in my talk. Okay, so now I serve as the Executive Director of Pregnancy Care Canada. We are a national best practice affiliation of local pregnancy care centers. There are over 80 centers that are in our network, and we help to establish new centers. So if a community starts to think, maybe we could do something, maybe we could open our doors, we will work with them. We then provide training, resources. We have an annual conference where we also provide spiritual encouragement. We are a Christian organization, and that is a deep a foundation of how we do anything that we do. We want it to be glorifying to God, and we will say that we're Christ-centered. We're not cause-centered. Our vision is that we believe that every individual impacted by an unexpected pregnancy should have access to compassionate care and accurate information. There's a study, and one of the abortion doctors and euthanasia doctors that's been mentioned already was part of this study, but in it concluded that 1 in 3 Canadian women will have an abortion in their lifetime. And so that's also something, that statistic, I think, is important for us to be aware of, because we need to be mindful of our language if we want to build bridges to discussion. So in any room, it is important that we remember that the person sitting right in front of us maybe has had that experience. And human nature, sometimes people don't want to have to confront something that is painful. So I think it is important that we are aware of how we talk. When I was speaking at an event not long ago, I shared that statistic, and afterwards, when everyone had left, this young woman came up and she said, I'm that 1 in 3. And I wish I had known about the Pregnancy Care Center 7 years ago when I had an abortion I didn't want. She said, I remember lying on the table with the tears streaming down my eyes, down my cheeks. And she said, nobody was really there to help encourage me, to help me believe that I could do this. And so my hope and prayer is that that day she did start on a healing journey. And it is often the women and men who've been through an abortion experience who end up having a very loud and effective voice, a meaningful voice. Only 2 weeks ago, I was speaking in Peterborough, and I've written this book, which I will bring in at the end. It was raining and I didn't want to wreck my hair, so priorities. But the security guard who was assigned to the event that night, he didn't know what the event was for. It was a fundraiser for the local pregnancy care center. And I spoke, and afterwards he said, well, I want to sign up as a monthly donor so I can get a copy of the book. And for the rest of the night, I could see him reading the book, and I thought, I have to go talk to this fellow afterwards. And on the way out, I had the chance to connect with him, and he said that 3 years earlier, his wife got pregnant, and he didn't know about it. She spoke to his sister. She had the abortion. She wasn't doing well, and he wasn't doing well either. And he said, I have to own the fact that I wasn't a safe person for her to speak to, but I also hope that maybe one day I can be a voice for other men as well. So those stories are encouraging and meaningful. So getting into some data, and I realize it'll be very hard to see this, but it is in your handout. I saw that Jackie included it. So in Canada, the statistics organization is the Canadian Institute for Health Information, and this is the latest abortion data that is available from 2023. And I've highlighted at the bottom, so the total number of abortions that are recorded are 101,553. And so, honestly, I don't know what that number means. I don't believe it's accurate. That's just what is reported. And it really hasn't changed over the years. If you look at numbers from the past 10 years, they sort of go up and down. So we can falsely believe that things are changing, but I don't think the data is good. And so data that's incomplete, we have to have a measured approach to how we use it. With this Canadian Institute of Health Information, the gaps in the accuracy are that it's only from the hospitals have to report on their induced abortions that are performed. So those numbers we can believe are accurate. But the abortion clinics or any clinics outside of the hospital, they do not have to report their data, so it's voluntary. So I have no idea whether clinics would report or not. There's no legislative requirement. And so we have to assume that that is a number that's underreported. And as the use of the abortion pill mifegammizo increases, I think we can assume that those abortions are going to take place outside of a hospital setting. So again, there are likely many abortions that are not being captured in this system of reporting. Some people have wondered, well, could we just count the number of prescriptions dispensed for mifegammizo? But that again is not accurate because that drug is used for other purposes. And sometimes people are surprised about that. I know I was when I first learned that the abortion, what we call the abortion pill mifegammizo, that is used for incomplete miscarriages. So the medical professionals are using it for different reasons. We can also look at the change in the statistics of what we're recording for the medical abortion or the abortion pill. So that has gone up from 2018, it accounted for 7% medical abortions. Now it's up at 41.3%. And that will likely increase because it really is a focus of what the abortion advocates are fighting for: increased access, using teleprescribing, being able to access the pill easily. That number is is likely going to increase as a percentage of the total abortions. And we're seeing that in the states where the number of medical abortions the percentage has increased up to 63% of all abortions that have been reported and captured. So again, just grabbing the insights from data, we do need to assume that the medical approach to abortions, induced abortions, is something that's going to keep increasing. So what does it look like to show up in that space and have to be effective? Another bit of data that I think is useful to look at, again, this is from the data that we have, so acknowledging it might not be completely accurate. But it's this group. So the age group, women over the age of 30 accounted for 44% of all the abortions that were recorded. That makes me wonder, like what's going on? That's a significant number of older women who are having abortions. So when we think about how do we show up and help bring change, it's important to consider, are these women who maybe don't want a third child in their marriage, or maybe it was an accidental pregnancy, like what's the story behind it? Because sometimes we can assume it's the young teenager and the pressures that she might be experiencing. So that information we can glean from the data, and just be mindful that as we try to reach out and offer support, we need to be thinking about these older women who are making this decision. Looking again at the numbers, it is reasonable to assume that 1 in 5 pregnancies ends in abortion. 1 in 5. So that number is taking the total number of live births in Canada, the total number of abortions reported, that's the denominator, and then you divide that by the number of abortions. So that's where the 1 in 5 comes from. So and that again hasn't really changed over the years. I'm talking to people who know all about this, but just for the sake of being clear, so Canada has no abortion law. The existing law was struck down in 1988. And so any restrictions are primarily in the medical field. So they may be guidelines in a clinic, or there could be provincial guidelines, but there are no federal laws restricting abortion. And it's interesting to speak to people from different countries. They're shocked that we have no abortion law. It seems like a remarkable void in our federal legislation. An area where I think there's a lot of potential, and I think it's something that has been revisited and revisited recently, is the area of consent. So for medical consent, there's only one province that has a minimum age of consent, and that's Quebec. So a woman has to be at least 14 to consent to an abortion. But in no other province is there a minimum age. It is up to the subjective interpretation of the healthcare professional whether or not the patient seems to understand. And this is from the Canadian Medical Protective Association. So that is the group that most physicians get their malpractice insurance from. And I will say that if there's a pressure point for doctors, the fear of being sued or having a complaint lodged against them, that is a very vulnerable spot. And it might be time to push on it a bit. So yeah, so the CMPA says that the consent must be voluntary, the patient must have had the capacity to consent, and they must have been properly informed. Patients must always be free to consent or refuse treatment and be free of any suggestion of coercion, or duress, or coercion. And in terms of informed consent for abortion, again, it's just very subjective. What does the physician think somebody needs to know? And again, I can speak from experience where my informed consent might have been just making sure they knew it was permanent. You know, have you talked to someone? Have you considered the other options? But there's really no other guardrail there to ensure that people have time, space, that they understand the fetal development, that they really know what it is they're undertaking. So again, maybe potential here. I also found, this is also from the Canadian Medical Protective Association, saying that the legal age of majority has become progressively irrelevant in determining when a young person may consent to his or her medical treatment. The concept of maturity has replaced chronological age. And I think the ethicists probably deal with this stuff all the time, but how do you then, if you have a 14-year-old in your office and you're just not really sure, they might seem mature at that moment, they know what they want, but do they really have the full understanding? So how are we helping to protect them in some of these really difficult decisions? I already mentioned about the incidence of abortion. 1 in 3 women are projected to have an abortion within their lifetime. And this one, 41%, so this is data from the US, that of women seeking abortions, 41% had a prior abortion. So that's important too. What's happening afterwards? And I know one friend of mine, she had 3 abortions. Her first one, she was 15, and she wanted the baby. But her parents said, if you keep this baby, you'll have to move out of the house. So she had the abortion. Not long after, she was still a teenager, and she got pregnant again. And this time, she and her boyfriend were going to have the baby. And then her boyfriend's mother and sister phoned her and said, you're being selfish. You'll ruin his life. And so she had her second abortion. And with each one, she felt she got more into addiction, depression. She didn't feel great about all this. And then she was still a teenager when she had her 3rd pregnancy. This time she was fully into addiction, and she just didn't care about life. She didn't want to bring a child into the world. Her baby was 22 weeks. She had no idea how developed the baby was, and she had her 3rd abortion. And the doctor just said to her, you know, abortion isn't birth control, and you probably won't be able to have any more children because of the abortions. And she didn't realize what had been going on until she did get pregnant then with her 4th child as she was a bit older, with her husband. And then when she saw the fetal development, when she understood that, it just was devastating. And again, from the work that we do in this pastoral space, we know that there's often that absence of a voice just saying, hey, you're not alone. Let us show up for you. Let us help you. There are other ways to look at this. The abortion pill, again, Canada was more delayed in getting this, but then we seem to go on an accelerated path with these things. So it was approved in 2015, and then it was available for use in 2017. And as I mentioned, it's really changed the landscape of abortion provision in our nation. And when it was first brought out, there was a course that you had to take as a physician. So I signed up. In order to prescribe it, you had to complete this course. So I went through it, and there were there were strict protocols about what had to be done. But over time, these continue to be relaxed. So I will touch on those a little bit. So before we had to complete the course in order to prescribe, so that's gone now. It also had to be prescribed in the physician's office and dispensed in the office. Now it can be prescribed by nurse practitioners, and also the pharmacist can dispense it. So it isn't as, it was a bit of an unusual dispensing rule, I will say that. But now the pharmacist can give it out. It still has to be a prescription by a licensed health professional, so physician or health practitioner or nurse practitioner. There is no longer a requirement for an ultrasound before prescribing. And this, along with all the telehealth prescriptions, this is a bit worrisome. So the ultrasound, the purpose of the ultrasound was confirming the location of the pregnancy and also the gestational age. So initially the drug could be used up to 7 weeks gestation. And one of the contraindications or reason it couldn't be used was for an ectopic pregnancy or a tubal pregnancy. This particular medication does not cause the demise of an ectopic pregnancy. And so there's a risk that if there is a growing embryo in the fallopian tube, that it will rupture and cause a life-threatening situation for the woman. And it can happen around the same time. So it might be at 8 weeks. So the woman maybe took the medical abortion thinking that this bleeding and pain is from the abortion, and it could be from an undiagnosed ectopic pregnancy. But the decision makers feel that it's a low enough risk that they don't require an ultrasound. That can be a barrier to people accessing the pill. And in terms of I'll just go down here. So when it was initially prescribed, it could only go up to 7 weeks, but now up to 10 weeks. The product monograph, which is that piece of paper that comes in a box, it says 9 weeks. But the Society of Obstetricians and Gynecologists of Canada, they're the ones that the physicians listen to on this, and they say it can be used up to 10 weeks. So the length of time that it can be prescribed has increased. On that piece of paper, it lists the side effects. So uncommon ones, those are the serious ones that you'd pay attention to if you were going to take a drug. You want to know, like, what is the potential of this being a very serious side effect? So hemorrhagic shock, infection, sepsis, severe bleeding requiring blood transfusions. Those are considered uncommon or less than 1%. The very common ones make sense given the drug, so nausea, vomiting, diarrhea, abdominal pain. So if you were a patient and you were deciding to take this, you'd be thinking, okay, so I might not feel well, but those more serious ones are uncommon. You know, they might make a decision based on that. But what we did recently, this report was released from I don't get the term right, Alex, it's the group you're with too. Hang on, it's the Ethics and Public Policy Center. So this was released only about a month or so ago, and it was regarding the safety of the abortion pill. And what they did was they took all the claims to the insurance providers, so there were over 865,000 insurance claims made by people who had had a medical abortion, submitted to the insurance providers, and then the reviewers were able to look at the incidence of serious adverse outcomes within 45 days of taking the abortion pill. And what they found was a very surprising incidence of serious side effects. So rather than it being the uncommon side effects, it was the common. So 1 in 10 patients had serious adverse events. So sepsis, infection, hemorrhaging. And so that it sort of flipped the percentages of what has been assumed. Now, in the work that we do, where we're advising patients or clients who might be considering some of these things, there's been some questions like, do we change what we're saying about the abortion pill? And that's where I do want to underscore that if we want to influence at a legislative level or the decision maker level, the scientific data, we want to be as robust as possible in the data that we're collecting. So there have been some concerns about this report, but I think it's the canary in the coal mine, like it's going to cause some attention. So there, in one of the Catholic reviews in May, an organization, they had some, hang on, I've got to read their qualifications here. So they asked some doctoral level faculty in both public health and research to review how the data was collected and analyzed. And so they do have some concerns that because it didn't undergo a peer-reviewed process, that it may not be adequate, that the validity of the claims are uncertain. And so I'm okay with them saying that, because we want to say that anyone with they don't have to have a particular worldview, but can we scrutinize data and say, this warrants more attention? Is that really true? Is this pill really as unsafe? What else should be done? So I think, again, it's part of making sure that the data that we have is helping to inform the decisions that are made for tomorrow. This next slide that I'm going to show, I made up this name, Sasha. And I made up her name because she is a young woman who died from complications of the abortion pill. And I wanted her to have a name, and I think, again, Jackie put this in your package. So this will be a hard slide to read. It's too small, but I will just highlight it. So this is from the adverse, sorry folks, the adverse summary of the reported adverse reactions. So again, this collection of data is voluntarily provided, and it can be provided by medical professionals or just lay people. So Sasha was 19 years old, and I'm gonna have to look up there. In 2022, she received mifegamizole, and she developed septic shock, and she died. Fatal outcome. Now, they didn't indicate in the form what the indication was, but I think it's safe to assume it was for an induced abortion.
Laura, it always amazes me that it says death, yes, life-threatening, no.
Right. Yeah. I did notice that. But it does make you, we can look at these numbers, but then you think about the people in her world and Sasha's world, like maybe they didn't even know, because abortion can be a very hidden choice that women will make. She maybe was hiding at home, not wanting to tell anyone that she'd gone through this. She wasn't feeling well, she didn't seek medical attention, and then ended up with this catastrophic outcome. So again, it's pretty devastating. Another patient, or not patient, another victim, I suppose, Tiffany, I want to highlight a bit from her report as well. So Tiffany, this was from 2019, 17 years old. She also was given mifegamizole, and they do indicate on this that it was for an induced abortion. And then she has this long list of adverse reactions, so including circulatory collapse, sepsis, septic shock. And they say it was life-threatening, but then they do say recovered, resolved. And that one I find how do you recover and you're resolved? 17 years old, her body went into shutdown because of sepsis. Even if physically she recovers, what is the emotional aftermath of going through something like that? Again, because of the secrecy surrounding abortion, I often am wondering, like, who even knew about this? Did her parents know? Did her friends know? Did her partner know? So we can look at the physical complications, but there's also the emotional underbelly to abortion and the side effects of it. And I know that you have done some research on this. This is the one that is from 2017, Priscilla Coleman. And what she did was they looked at statistics from 987 women who reached out to a local pregnancy care center for support after their abortion. So again, this is a biased cohort. This is not for the general population, but for this particular group of women, it's still significant. So 3/4 of these women experienced some form of pressure from others to have an abortion. 58% of them reported aborting to make others happy, and 66%, or 2/3, knew at the time that they were making a mistake. So again, it highlights the importance of how are we really helping women and men to have that sober second thought, to have that pause, to consider the decision that they're making, and to make sure that no one is pressuring them into an unwanted abortion. And again, it might be a nuance that in this room might not seem comfortable, but in the general population in Canada, most people agree that no woman should be pressured to have an unwanted abortion. So that is a place where we can all potentially agree, even if we don't agree in all of the details. And now, if it works, I'm just going to show a short video of a woman that told us her story, and we were able to capture it on video.
I grew up in a very traumatic household. I didn't believe I was valuable or worthy, and so when my boyfriend told me that if you ever get pregnant, it's abortion or nothing, I was so desperately in love with him and felt that apart from him, I was nothing, that I said, okay. I found myself pregnant, and I just wanted to do what I was told so that I could be loved. I had the abortion, and a few months later, he broke up with me. I didn't want to share with anyone that he would put me in that position because I loved him. I honestly felt like there was nowhere I could go. There was no one I could talk to. I came to the Pregnancy Care Center. It was honestly the first time in my life that I felt safe, accepted, in a space with people who could truly understand what I had been through without any judgment. Because as a woman that did not want to have an abortion, I never felt accepted anywhere else.
Yeah, she's brave and allowed us to use that a bit for social media and just to tell the story, because sometimes there's an assumption that people have about why women do choose abortion. This study by David Reardon, Dr. David Reardon, was published earlier this year, and it was interesting because the study sent a survey to 2,800 American women between the ages of 41 to 45, and so they didn't know what the study was about. But they were asked about a history of suicide and also their reproductive experiences. And then they were able to drill down if someone had experienced suicide and had an abortion. They were able to look into that and have a correlation about that. And so the study did show that women who had experienced an abortion were twice as likely to have attempted suicide compared to the other women, especially if they had experienced a coerced or unwanted abortion. So again, it's highlighting some of the emotional cost and impact that may never be talked about.
Oh, sorry to interrupt. We're trying to raise money to do one here. It's going to cost us about $5,000. So if anybody has a free $1,000 anywhere, we need 5 to do a Canadian one just like that.
Yeah, and I've so appreciated the effort that you and the others are doing to try to get Canadian research, because sometimes, you know, it might not be as listened to if it's done in the States, but to have Canadian research, Canadian data, that would be fantastic. So in summary, I do believe that we need high quality scientific research, and that research will lead to more effective policies. And I say we have to believe this. We can't believe that there is no role in the scientific validity, which even in a worldview, in a Christian worldview, science supports Christianity. And so there's a connection that can be made. Complications matter. I don't know, it's disturbing to think about the euthanasia, the assisted suicide stories, and the lack of reporting, the lack of care in how this is being delivered. And I have concerns about the women that are in remote areas who are undergoing these medical abortions by telehealth medicine. Do they have backup care? Do they have access to emergency services? How do we really put guardrails in place for informed consent? And I think we can all agree that we'll make decisions we might regret, but how do we help women truly make an informed decision and not feel like they weren't told the truth, told the facts, or given alternatives? Coercion and unwanted abortion exist in our nation. And this is something that was spoken about already today, that despite all of this brokenness in our world, may we not lose hope and our mandate to love. And this verse from 1 Corinthians, that these 3 remain, faith, hope, and love, but the greatest of these is love. And that is my prayer, that we would be voices of truth and voices of love, and that will give us a voice of influence. I'll try this last little video just to show some of the statistics of the impact of the local pregnancy care centers across Canada, the showing up in that space where there can be uncertainty and fear, so that people can find hope.
Let me be filled with kindness and compassion for the one for whom you love and gave your son for humanity. Increase my love, help me to love with open arms
I'll bring in these books after, but I have written a book. It's, I wrote it. I'm not the greatest promoter of it, but I wrote it, and it goes through mostly for Christians who maybe feel uncertain about how to engage in the abortion conversation. They back off because they feel ambivalent. Maybe it is the best thing, and that's some of what I've heard when I've spoken to Christians. So helping them understand, like, we first, remain anchored in what we believe and know to be true, and then we find ways to extend grace and invite hope and change. So I will bring those in at the end. And then if you would like to get connected with Pregnancy Care Canada, please do. This is a QR code for our newsletter. I don't know if it works this way, but our website is pregnancycarecanada.ca, and there's a sign up on there. So it'd be great if we could track together. And if you would like to speak with me or connect with me, my email is laura@pregnancycarecanada.ca. And that is the end of my presentation. So thank you very much.
Maybe we could take a couple questions. I'm going to start with one. We're considering a resource center for material goods. Is you guys involved with that too, or more the client relationship?
Most of the pregnancy care centers have a closed closet, or they might partner with a church that would have the physical goods. So yeah, it could be a mixture of how things are done.
Sure. Okay. Any other questions?
Thank you, Laura, for your presentation. Very informative. I've got a couple of things I want to ask, and just to be brief. About the abortion law in Canada for approximately 40 years or whatever, what is the rate of growth? What's the curve or the line, the slope for abortions in Canada? Have we increasingly exponentially gone higher, or is it sort of roughly on an upward decline, but it's sort of flatlined? What is your understanding? And can I just give the two if you have time?
Yeah.
The Guttmacher Institute is the research arm of Planned Parenthood in America. Is there an equivalent or similar a center like that in Canada? And thirdly, are there any meta-analyses of some of the studies that you've been talking about and are being researched in Canada?
Okay, test my memory. I guess what I was trying to express with that Center for Information and Health, the statistics, I don't believe it. So I don't know that we know, because the numbers have been fairly steady, but because the data in isn't complete, the data out isn't reliable. Now, I do believe that there's a more cavalier approach to abortion, that our culture, the idol of autonomy and self-determination, all those things are increasing. And I think there is a generation that probably was more readily willing to have an abortion without thinking too much about it. So I wouldn't be surprised if it's been climbing, but I don't know that we really can see it in the actual national statistics. The Guttmacher Institute, I don't know if there's one in Canada. No, okay.
The Dever Institute.
Dever, but they're more
Doing research.
Yeah.
They do research. It's where we get research.
and then in terms of meta-analysis, not that I'm aware of, I think that's why it would be
But
great.
there's Cardus. I mean, Cardus do a lot of, in Ottawa, do an awful lot of research. But
Cardus,
not really,
yeah.
Not really on the same level.
Like what Dr. Reardon does in the States, like he did a big one on regret in abortion, looked at all these studies and did that meta-analysis, but I'm not aware.
There is in the States two clearinghouses that are not just on this issue, are the NIH, National Institute of Health,
Yeah.
which is a clearinghouse for scientific data when it comes to the medical system. So it's just not an abortion and so on.
Yeah.
And there you'll find, from an American point of view, a lot of meta-analyses of some of these issues. Also, there's another one, I think it's MILF or something like that, that is also a
NIFLA.
clearinghouse with that, and that's what I was wondering about in Canada.
Oh.
Whether-
Yeah,
Unless
you
the
might know
Canadian
better.
Institute for Health Information and the Canadian Institute for Health Research, it could be either of those, might do something, but not, I mean, the bookmarker is really the pro-abortion side of everything.
Yes.
We haven't got a pro-life side of everything here in
Yeah.
Canada.